for the my apology for the technical problems. I am actually a pediatric emergency physician at SickKids and a clinician scientist at the SickKids Research Institute. And my primary research interest is actually optimizing management of acute respiratory disease, such as, for example, acute asthma, bronchiolitis, and croup. So let us take it from here. So today we are going to talk about management of severe acute asthma in preschoolers. And over the next hour or so, you will hopefully get some idea about making a presumptive diagnosis of asthma in children that are of the preschool age. We are going to discuss a pediatric respiratory assessment measure, also known as Pram, and therapy based on the Pram. We are going to talk about timing of the corticosteroid therapy and the rationale for the dose of the corticosteroids, indications for intravenous magnesium as a step-up intravenous bronchodilator, and we'll talk about how much of a benefit there is actually for this treatment. And finally, we'll talk about discharge therapy criteria with inhaled corticosteroids and how long you should prescribe this for. Okay, next slide. So just imagine yourself that you have a 16-month-old boy in your emergency department with a second episode of wheezing. This child has had a previous ED visit 3 months ago with wheeze with a good response to therapy. He's healthy with no atopy, but he's quite sick. So he's grunting, he has chest retractions and neck retractions, and a lot of wheeze. His saturation in room air is 88%, and he's quite tachypneic. So can we get an idea how many of you would vote for a diagnosis of asthma in this boy as a presumptive diagnosis? So Stephanie, I guess we may not have a lot of time for the voting. So just keep the thought and we'll move to the next slide. What exactly is asthma? So this is actually a slide that I have borrowed from one of my colleagues in the respiratory division, Dr. Subarao, who has been doing a prospective child study for many, many years. And she discovered that the majority of infants or young children with a wheeze episode actually improve by the time they go to school. However, many do not by the time they are about 5 years old. And of those that eventually receive an asthma diagnosis at the age of 5 years, about a half have preschool onset wheeze, 27% have persistent wheeze, so even in between colds, and 12 only have transient wheeze. And these children with a diagnosis of asthma at the age of 5 have abnormal lung function. In many of these children, this abnormal lung function continues unless the inflammation is appropriately managed. And this implies abnormal lung growth and high risk of future COPD. So therefore, there is a Canadian Thoracic Society statement from 2015, which tells us that children who have had a second episode of wheeze in the past 12 months are otherwise healthy, and they either come to the ED for wheeze in the past 12 months, or they had to receive corticosteroid therapy in the past 12 months. These children are at high risk for asthma. So please remember that if you see in the emergency department a child with a second episode of asthma ever, who actually requires therapy in the ED, especially if this state is reversible after therapy, that is presumed asthma until proven otherwise. And the first episode of wheeze can also be assumed asthma, provided that the child is responsive. Now, remember, this is in children over the age of 12 months. Okay, the next slide, please. In contrast to bronchiolitis, which I'm sure some of you are going to ask, which happens by and large in kids under the age of 12 months, it is the first episode of wheeze, and it does not respond to treatment, and treatment should not be given for bronchiolitis, generally speaking. Okay, next slide. Okay, so you may have heard about the Pram score. So the Pram score is actually it's an instrument for acute asthma, which consists of these 5 items that you and I use for assessment of acute respiratory distress. It ranges in severity from 0 to 12 points, with 0 to 3 being mild, 4 to 7 points is moderate asthma, and 8 to 12 denotes severe asthma. Okay, next slide, please. So this particular asthma measure has been validated for children between the age of 1 and 17 years. It has been shown to have a strong association with hospitalization and actually represents a standard of care across pediatric emergency departments in Canada. Next slide, please. We actually base our treatment of kids with acute asthma on the Pram score. So if they have 3 points or less, they get 1 treatment with salbutamol. And if they have a Pram around 3 or so, then they also get a dose of corticosteroids. Kids that are of moderate severity, they get 3 treatments of salbutamol in a row, usually 8 puffs each. And those that have a Pram of 8 or higher get also Ipratropium for 3 treatments. And intravenous magnesium is considered, especially if the Pram stays above 8 after the initial therapy, with 3 treatments with salbutamol and Ipratropium. Next slide, please. Okay, so generally speaking, in the ED, we use the meter-dose inhaler with an aero chamber to deliver the bronchodilators. And these are all the advantages. It produces a very short treatment time. It allows very close spacing of treatments. With an MDI, you maximize the lower airway delivery of the drug, and you minimize the side effects by minimizing the drug deposition to the upper airway, which is where it is systemically absorbed. MDIs have come into fashion at the time of SARS in 2003, when it was thought to be, when the nebulizers were thought to contribute to risk of cross-infections. Whereas MDI minimizes the risk of cross-infection. And importantly, its use provides a wonderful educational opportunity for the families so that you can show them how to use it properly. Next slide, please. Now, it is important to use enough beta-2 agonists in young children. And the reason for this is that young kids have lower inspiratory flows. They have a small airway caliber. And also, when they cry, there is actually a lower deposition. So as a rule, the dose of inhaled drugs should not be weight-based. And the big and small kids deposit approximately the same amount of drug per kilogram of body weight into their lungs. So we generally use somewhere between 8 to 10 puffs per treatment for all children, regardless of their size. The MDI actually compares very well to the nebulizers. This is a systematic review which showed that MDIs result in shorter length of stay. They produce fewer side effects. The families generally prefer the MDIs as well, and it can be used not only in the ED but also in the intensive care unit. Okay. Now, what about Ipratropium? Ipratropium is actually synergistic with beta-2 agonists, but it is effective in only severe disease. So generally speaking, with kids that have Pram of 8 or so or more. And in a key paper listed here, it has been shown to decrease hospitalizations in severe acute asthma. Generally speaking, 3 treatments with Ipratropium are actually enough. So you don't have to continue it thereafter. Now, what about corticosteroids? So there is plenty of literature that shows that oral corticosteroids decrease hospitalization, and they are indicated in virtually all patients that require therapy in the emergency department. It's very, very important to give corticosteroids early in order to prevent hospitalization. And there is actually, this is a very useful reference that shows that giving them in triage actually decreases the hospitalization rate and the time to ED discharge. So what do we use? We use dexamethasone, which is a very yummy preparation that's very well tolerated. And the usual dose is 0.3 milligrams per kilogram. You can give 2 daily doses, or you can give a single dose of 0.6 milligram per kilogram, which generally speaking lasts for the next 5 days in the body. If you use prednisone or prednisolone, the dose is 1 to 2 milligram per kilogram for 5 days. Next slide, please. Okay. Now, why do we use dexamethasone versus prednisolone? It has to do with the biologic half-life. With dexamethasone, as you can see, it's somewhere around 50 hours, whereas that of prednisolone is only about half of that. When we compare the anti-inflammatory potency of dexamethasone to prednisolone, it's approximately 6 times more potent. One question that frequently comes up is dexamethasone actually, should we give 1 dose of dexamethasone or 2? And what is the total dose of dexamethasone that's required? Okay, so let me tell you that there is actually not a good evidence to answer this question, but just bear with me and follow the following. So if you give somebody 2 milligram per kilo in the ED, followed by 1 milligram per kilo for the next 4 days of prednisone or prednisolone, that is equal to total of 6 milligram per kilo of prednisone, which from the ratio I have just shown you corresponds to equivalent dexamethasone dose of approximately 1 milligram per kilo. So if you say, okay, so I give 0.6 milligram per kilo per dose, then that means that we should give 2 doses of 0.6 milligram per kilo each. However, there is not a single study that actually substantiates that. For reasons of simplicity, as well as compliance at home, we actually frequently give, in fact, almost always, dexamethasone 0.6 per kilo as a single dose. And that seems to be just fine without patients coming back. Next slide, please. However, this is not necessarily the end of the story because some children do not respond to this standard therapy. The benefit of steroids is often apparent within 4 hours, but sometimes not. And some children do not respond to the beta-2 agonists very well. And this has to do with the adrenoreceptor and the corticosteroid gene polymorphism. So up to about 30% of children that you see in the ED are resistant to the initial treatment with beta-2 agonists and corticosteroids. And this represents the majority of asthma hospitalization. So there is a need for a second-line bridging agent. Next slide, please. So just imagine yourself for a minute that there is a 6-year-old girl who comes with acute asthma after a cold. And she's had previous ED visits and now also has had intermittent wheeze without colds. She forgets to take her Atrovent therapy, but she's sick. And she has difficulty talking in full sentences. She has an audible wheeze. Her saturation is 91% and she has a Pram of 11. Next slide, please. So she has a severe acute asthma. You treat her as usual So she receives dexamethasone, 3 treatments of salbutamol, 8 puffs each. You give her Atrovent, and at 30 minutes, she has a Pram of 8. So she's not much better. What is the next step? Next slide, please. So this is the menu that you basically have. Intravenous magnesium sulfate, high flow nasal cannula, and there is other therapies that are like intravenous salbutamol, which is given in the ICU setting usually, and aminophylline or ketamine, which I'm not going to talk about, but they are given very uncommonly with very dubious evidence of benefit. Next slide, please. Okay, so these are all reasons why intravenous magnesium may theoretically be beneficial. It is important to remember that a dose of 50 to 75 milligram per kilo is required to achieve magnesium therapeutic concentration time profiles. So this, pharmacologically speaking, at least 50 milligram per kilogram is important. Next slide, please. Now, this is a situation where you may want to consider giving intravenous magnesium. So children who are in extreme distress on arrival, which by the way is very uncommon. So if you have someone that has a Pram of 11 or 12, and that is something that you would consider. If you have treated the kid with with bronchodilators and corticosteroids for the initial hour, and the Pram is still around 8, that is something that that may be on your list to give. The half-life of intravenous magnesium is actually quite short. It's only about an hour and a half. So all children that get this need to be observed for a minimum of 2 hours before being discharged, which majority of them are not. And it has to be given as an intravenous infusion over about 20 to 30 minutes because intravenous magnesium is not only a bronchodilator, but also a vasodilator. So there is a risk of hypotension with rapid administration, somewhere in the neighborhood of 6 to 8%. Personally, I find it's much lower. Because most of these children are dehydrated, it's not a bad idea, by the way, to give them a pre-treatment with a bolus of normal saline over about 15 to 20 minutes while your nurse is getting the magnesium infusion ready. Next slide, please. So what is the evidence for actually magnesium benefit and how is it being used? So this is a huge PCARN registry from the United States, which is a big network of pediatric emergency departments. And they found that only about a quarter of kids who are admitted for asthma get intravenous magnesium, and the discharge is only about 10%. So it's given very variably, not terribly frequently. And the question is, what is the revisit rate within the next 3 days after intravenous magnesium? And this is the data from the same registry. And you can see that actually, if you give IV magnesium, it's pretty low and it's only half than without IV magnesium. So there is some evidence that you can actually send suitable responders home. The second one is an interesting study from the US, which actually shows that although the rate of IV magnesium use over the last decade has doubled, there has been no reduction in hospitalizations or ICU admissions. Okay, and then there are also several randomized trials. As you can see, the total number is very, very small. And these randomized trials have reached disparate benefits. So 2 of them have shown a big difference in hospitalization, whereas the last one has shown no benefit at all. There is also a big systematic review by Griffiths, which actually critiques the limitation because there is only 115 patients. They have reanalyzed, they have combined the entire conglomeration of the results, and this actually turned out to be a non-significant result. So the bottom line is that we actually don't know whether intravenous magnesium in children is beneficial in decreasing hospitalizations. Next slide, please. And these are examples of 3 recent studies, one of which we actually did at SickKids, where we found the results show that the patients that get intravenous magnesium have approximately 6 to 10 times higher odds of admission, independent of asthma severity or response to IVMG. In other words, the intravenous magnesium therapy is just the fact that it's given prompts many physicians to hospitalize because they don't know that there is enough evidence, and they are not sure that that it is actually safe to discharge these patients home. There is also evidence in these studies that shows that IV magnesium is not associated with decreased length of stay, need for airway support, or time to salbutamol every 4 hours when you can send the child home. Next slide, please. Okay, high flow nasal cannula. So this is used in asthma in patients that have severe disease. The benefit being is that you use a heated, humidified airflow or oxygen at higher flows than with traditional oxygen therapy. Flows of 2 liters per kilo or higher provide some positive pressure throughout the respiratory cycle. And there is evidence that they also deliver a modest incidental PEEP. You can use it not only in the emergency department, but also on the wards and of course in the ICU. Next slide, please. These are all the benefits of high flow. You get higher functional residual capacity in asthma. It decreases airway resistance. It also flushes nasopharynx and increases the CO2 clearance. And it helps patients maintain their oxygen saturation. Okay, the next slide, please. Just a couple of words about intravenous salbutamol. There is some disparity between guidelines in terms of whether or not it should be given. And this has to do with the fact that the evidence is actually rather flimsy for its benefit. My guess is that the reason for that is because it's very difficult to conduct these studies. Nevertheless, intravenous salbutamol is frequently used in ICU setting in refractory asthma that does not respond to everything I have mentioned, including magnesium, where the patient has increasing oxygen demands despite high flow and maximized therapy. It does have higher toxicity risk than compared to inhaled. Specifically, patients can get anxious, they can get lactic acidosis, increased tachycardia, and there is also increased respiratory workload, which of course demands intense monitoring. Okay, the next slide. So let's pretend that you have actually miraculously managed the patient and the patient is going home. So all patients that go home from the ED need to be sent home on inhaled salbutamol through the MDI and the aero chamber with a dose of somewhere between 4 to 8 puffs, frequently 8 puffs, every 4 hours as necessary for the next several days. We usually tell them to remain on 8 puffs for the next day or 2, and then increase the interval between the puffs and decrease the number of puffs. If you have given them a single dose of dexamethasone in the ED, they usually need nothing else. Because you want to improve and maintain the improvement in the inflammatory process, our Canadian Thoracic Society colleagues tell us to send all these patients home on inhaled corticosteroids for the next 12 weeks. So these patients routinely get a prescription for inhaled fluticasone for the next 3 months. The reason being is that the prescription for this inhaled corticosteroids decreases the subsequent ED visits and hospitalizations by about a half. There is also evidence, by the way, that this is frequently not given by the primary care provider when these patients are followed up. Next slide, please. So the key messages is to please consider asthma diagnosis in all recurrent wheezers, especially those that have a good response to treatment. Corticosteroids should be given in triage to all children needing emergency department therapy. The treatment in the emergency department can advantageously be used on the Pram Score. Use of the MDI in the ED provides a good educational opportunity. You may want to consider intravenous magnesium after about an hour of standard treatment if the child has failed treatment and still has severe asthma, although please do keep in mind that the evidence for benefit is really not there. And finally, when the child goes home, inhaled corticosteroids is the way to go, for a sufficiently long period of time, which frequently the parents do not follow. So education is important. Okay. Diane.
Hi, everyone. I'm Diane Soros. I'm the clinical educator specialist for respiratory therapy here at SickKids. And so I'll go through, I actually don't have a lot to say today because I'll refer to some other talks that have already happened that hopefully some of you have been able to see. But this is our order set. This was the last paper copy of our order set that we created for our emergency department. So feel free to utilize this as much as possible. Dr. Shu's already talked about how we utilize this. You know, when we usually contact RTs for Pram scores greater than 5. And then if we have a non-responsive asthmatic, we'll start to look at, you know, bringing in establishing IV access, the NPO status, and then checking potassiums. And so anybody who's staying then continues on to our continuing treatment order set. And so this is where a lot of our discharge instructions are. And so again, Dr. Shu's gone over all of this. I won't go over it too much. You're just welcome to utilize this in your own practice if you needed. And so critical asthma and the PICU admission. So Dr. Shu and you know, some of our physicians here at SickKids actually did a study looking at you know, at our asthma admissions over the years, and we are seeing increasing emergency visits for asthma, but we're actually seeing a decrease in the proportion of our PICU admissions. And I can attest to this, that this is largely due to the changes in our intensive treatment in our emergency department. And so just in my 20 years, I can tell you, you know, what we've seen. And so, you know, hopefully that, you know, with aggressive treatment in Emerge, you won't get to the point where you're going to have to manage these critical asthmatics. That being said, those who fail to improve with proper treatment should be considered critical and non-responsive. And so what I'm going to talk to you today shouldn't change any of your practice. The critical, you know, activation should happen right away for support and any of these things that we're going to talk about. So why do we see asthmatics in our PICU? Most commonly we see, you know, if we see delayed treatments, you know, delayed steroid use. Quite often, you know, we always say, you know, one for the road when we're transferring between units, because that's quite commonly when we see missed treatments. And if you do miss a treatment, it's okay to start over, right? And so if you've been weaning, you know, and you're down to Q hourly and all of a sudden, you know, they're now wheezing again, or they seem to have deteriorated a little bit, go back and just start over with your Q15 minute if that's where you were initially. We do have our non-responsive or atypical asthma. So, you know, if we have the continuous trigger, if we see our atypical genotypes, we know, and this is more and more coming, you know, the focus of research for so many, looking at these genotypes and their high risk for either, you know, severe asthma or intubation and rates and things like that. So I'm not going to talk too much about that, but just don't be surprised. You know, we've been working with our respiratory medicine colleagues to try and, you know, if they do have an atypical asthmatic, to try and send guidelines, and if there's something specific they would like us to do. So, you know, some of their patients, they prefer to have prednisone over Dex and things like that. So I've asked them to try and send out some guidelines with their family. So if a family is telling you that they're seeing here at Sick Kids with our respiratory department, try to follow those guidelines because they've probably, had some experience with that patient specifically. And then some of the risk factors. So, previous ICU admissions, syncope or a seizure during an asthma exacerbation, food-triggered events, 2 or more canisters a month, denial or failure to recognize illness severity. We see this a lot, actually. I've had a few kids come in and you can barely even recognize. They look fantastic. They're stoic, right? So they're just sitting there looking at you, and they're saying they're fine, and they're saying they're fine, but their stats aren't great, and they're really quiet. You can't hear a wheeze, and you give them a dose of bronchodilator, and all of a sudden you can start hearing the squeaks as they open up a little bit. So just be cautious with those kids, and depression and other psychiatric disorders as well. Okay, and so Madison made a comment that, again, one third of the children who die from asthma actually would not have been classified as high risk. So again, use these with caution. So critical non-responsive asthma management. Exactly what Dr. Shu said. We're gonna, you're gonna activate critical right away. You're gonna continue your IV meg sulfate from Emerge. You're gonna continue the corticosteroids, and then you're gonna continue, or you may add your IV beta agonists if they're unresponsive to meg sulfate. We'll talk about high flow. I know Dr. Shu talked about the mechanisms of action. We'll talk about non-invasive as well. And I just want to make sure, that just with the high flow nasal cannulas, again, this is not a replacement for therapy. This is supportive. So we don't want to use high flow in place of. And so I'll talk about that a little more. Okay. We do want to avoid intubation whenever possible. And so, we want to try to keep their active exhalation. And so we'll always prefer non-invasive with these kids, which is sometimes easier said than done. And then when we are, when unfortunately those times happen when we have to invasively ventilate, we're going to use our obstructive ventilation strategies and manual compression on exhalation. And I have done this multiple times, and it does buy us time at least until we can, as soon as you paralyze them and we lose that active exhalation, that's usually when things go wrong. So there are some talks I'm going to refer you to just because we don't have time today. On the Connected Care website where you joined today, there's a talk from my colleagues, Katie, who did a talk on heated high flow, mechanical ventilation, and non-invasive, and really just trying to work with the equipment you might have in your institution and some of the tips and tricks around how we can use it on kids. And then there is the talk Andrew Helmers did and Katie Reese did on managing asthma pending transfer to the tertiary care. Okay, so they talk a lot about some of the more advanced things that we'll do once they get here. But let's talk about high flow nasal cannulas. So again, studies are now coming out saying that generally it's safe to use on an asthmatic. But again, you need to be really cautious that it's supportive therapy, so we need to make sure that they are still getting their pharmacotherapy, and really just understanding what it does. So it's not, it doesn't ventilate, and it doesn't offer any sort of continuous pressure. So we will use it because non-invasive is quite difficult to do on kids, especially if you're not used to this. And the last thing you want to do is stress kids out. So because high flow nasal cannula is quite well tolerated, we will try this, if the kid's, moderately unwell, and we will actually try to deliver bronchodilators, inhaled bronchodilators through the circuit. I'm going to talk about how we do this, okay? Because it's not great, the deposition when you're using high flow nasal cannula. So either reducing flow or switching back to a mask is sometimes recommended. So I'll show you what we do at Sick Kids. Non-invasive, again, so may help to avoid intubations while we're waiting for pharmacotherapy to take effect. It is preferred over invasive ventilation, right? Just to maintain that active exhalation. And we do continue beta agonists whenever possible when we do it. And so the thing with non-invasive is that it is, you know, with adults, they tolerate it a lot better because they can understand. But kids can really, you know, if you're coming at them with a mask and they're freaking out, the last thing you want to do is to start increasing their metabolism and things like that and stressing them out. So I wouldn't do this without supportive critical. You know, and they may suggest some sedation, some light sedation or things like that. But like I said, you're not going to do this alone. So when do we switch from MDIs to nebulizer? And so this is quite often a common question I get, and it's been asked in other talks. So I wanted to make sure I had a chance to go over this with everyone. So we really will always use an MDI with a valve holding chamber. And so the only time we would switch is when they can no longer actuate the valve holding chamber, the valve. And you'll see and your chamber spacer might be a little different as to where it is. But if they can't actuate the valve anymore, it's time to switch to a neb. Or if they have really high O2 needs and they don't tolerate it coming off for the APAFs or the whatever they need. We will start on nebulization. Families who are well known to us will ask for nebulization when they come in based on the past medical history of this child. So this might be a repeat offender. And so if I have a family that's that, we're going to take their word for it and we're just going to switch. You know, they generally know their kids best. And then we do have some tracheostomies who have asthma as well, and they don't always tolerate the valve holding chamber attached to their trach. So I think where some of the confusion comes in is I think when you know the pediatric hospitals or when the you know the community hospitals are seeing our ACTS team come to pick up our children, they will always switch to the aerogen for nebulization during transport. And that's for all of our patients, not just asthmatics. And so for them, AGMP status is a huge consideration during transport, as well as their weight and how much equipment that they can carry. And so, you know, and so I think that this might be perceived to be gold standard, but that's not necessarily what happens once they get to sick kids. So I'll show you how we manage it. And so what we'll do is once they get to emerge or wherever they're headed, we'll assess the patient and we'll decide whether or not, we'll assess whether they can come off. So typically if they can come off their high flow nasal cannula, we will take them off to give them their meter dose inhaler with valve holding chamber. If you have them on high flow, the last thing you ever do is put a mask on over their nasal cannula. So please ensure that, you know, for those patients that you're doing this, that the nasal cannula comes out of the nose. All right. And I think it's all done honestly because they're trying to minimize, you know, how often we're handling these kids, but they're just really not getting their dose. So we want to make sure that mask, those nasal prongs come out of the nose. And then for patients who don't tolerate removal of high flow nasal cannula, we'll keep it on and we'll deliver it through the aerogen, we'll use it through the high flow nasal cannula. And so again, you're going to want some guidance with this. This is something that we put together for the RTs. I would use it with caution. I heard you were just chatting yesterday, and I think Aerogen is going to come out with some guidelines on how to do this. So this might change for us shortly. I think it's like 0.5 per kilo. Don't quote me. I haven't heard anything official. But what we'll do is we'll titrate the flow. So if they can tolerate titrating the flow, we'll bring that flow down to increase the deposition. And there's lots of studies I can share if anyone's interested on this, but you know, infants, it's not great, but there's quite a few studies. So infants less than 10 kilos will turn down to 2 liters, greater than 10 kilos in a toddler or a child will switch to 3 to 4, and then adolescents 5 to 6, whatever they tolerate. And if they don't tolerate that, really at that point, we're considering them severe asthma. And this is true of our non-invasive. So we will deliver our full therapy on their therapeutic flows. And so again, you're going to want guidance on this. Okay, so we titrate patient response because we know that the dose might be suboptimal, and more so with the high flow nasal cannula. We know that non-invasive may provide better deposition than high flow nasal cannula, so we just keep that in mind when we're looking at results and our dosing and things like that. We try to use a high efficiency nebulizer Okay, so just be cautious, when you're in training flows and things like that. If you're using a, jet, I haven't seen a study with jet nebs or small volume nebulizers talking about this, so I can't recommend anything either way. We always use a high efficiency. We do use the Aerogen, but whatever you have, see what you've got, and then there's this discussion about continuous dosing, and so we do use it. We use it more in ICU. Okay, so I think people think that you're giving your maximum dose that I've given is 20 milligrams, and that's really four doses in an hour. And so what I say is that if you're waiting for ACTS to come pick up the patient, hopefully that's happening. It should be. And you're just waiting at emerge, I wouldn't waste the time trying to figure out continuous dosing. Okay, it can take long. There was a comment that it took a team 3 hours, and the last thing you want to do is delay your pharmacotherapy trying to sort this out. So it's great if you're staying. It's great if they're going to be there for a while, and you want to do it just to try to minimize the hands needing to do this. But if you continue with your Q15-minute dose, you're still doing the same thing. So that's my take on, that's our take really on the RTs as a group on continuous dosing. And then we really only lower our dosing once we start to see the IV bronchodilator take effect. All right. And that's really all I have for you today. Feel free to, if there's questions on how to do non-invasive or high flow, or I don't think the mechanical ventilation is specific to asthma, so I'm happy to answer questions, but if there's anything, let us know. And here's a QR code for an evaluation we'd like you to fill out. All right. Any questions? Dr. Shu, was there any final comments on anything I presented?
Oh yeah, you did a splendid job. Diane, no, I think that I've actually learned a lot just from your talk about some of the ICU aspects. So that was great. So if anyone has got any questions.
Yep, there's a question. So for first-time wheezers, would start with early corticosteroids?
I think that you are kind of at the borderline between bronchiolitis and asthma. So I don't know exactly what age group you are talking about right now, but first-time wheezer over the age of 12 months, yes, I would start with corticosteroids. That's not to say that absolutely zero children with first-time wheezing episode under 12 months get any pharmacotherapy. If you have a kid who is obviously tight and who is maybe 9 or 10 months old, and the child is clearly atopic and the whole family has asthma, I think it's not unreasonable to give it a try and see what happens. But I think that that's really an exception. But the answer to your question is yes, you would give the corticosteroids. And beta-2 agonists and treat it as an asthma and basically see what happens. Okay, any more questions?
Hi, everyone. It's Tyler. I was just hoping to ask a quick question.
Hi.
For the synergistic effect of Atrovent,
yes.
Does it have to be given almost at the same time as Ventolin? And I'll give you a clinical example. So
okay.
I feel like commonly we're called and a patient might have gotten a back-to-back of Ventolin,
yes.
But not Atrovent. And then they've been able to be stretched to Q1 Ventolin. And then somebody might realize, their Pram score was probably high enough to get to that they should have gotten the Atrovent.
Okay.
So then they end up getting the Atrovent ordered as a back-to-back, which is given just Atrovent while we're doing Ventolin Q1.
Oh, I see. Okay. No.
So I guess I'm asking, do you have to give Atrovent and Ventolin back-to-back together for it to get the effect of the Atrovent?
Okay. So first of all, Atrovent is, just to put it into perspective, so Atrovent is actually not a very powerful bronchodilator at all. And I'll tell you in 1 second a little bit more about that. So generally, if you have someone that you think needs back-to-back treatments, you prescribe back-to-back treatments of both. So one is basically followed by the other. If you feel that the child has got a higher Pram, then I would just order three more treatments of both. But they don't have to be given together. No, you can actually pump you can give them extra Atrovent at the end if you feel that you have to. Just one interesting thing about Atrovent is that all the studies on Atrovent have been done on fairly lousy inhalation devices. And so the question really is still remaining is if you have someone who is really sick and you give them maximized bronchodilator therapy through MDI, how much exactly does Atrovent do to get them out of hospital? And that's something that we really truly don't know. So it's not a panacea by any means.
Hi, yes. Dr. Shu, there's a few questions.
Okay,
I'll put them in the order of, I'll try to put them in order. So the first question is it safe to give 8 puffs every 4 hours in the home setting?
Yes, it is safe, but I think that, I think education is really key, because what you have to tell the family is that if they feel that they have to give it more often than every 4 hours, they absolutely have to come back to see you. So that is very important. If you, and we usually limit it for about a day, because if the kid is truly well enough to go home, then they should not be on that forever. But yes, it is safe, but it's important to tell them what the red flags are.
And then how do you deal with sending kids home with 6 to 8 puffs Q4-hour PRN at home, and the pharmacist changing dose to 2 puffs Q4H PRN?
Okay, so that's a funny question. That used to happen a lot about maybe 10 years ago. It happens very infrequently now, at least to my knowledge. They used to phone, maybe they no longer phone and they just switch them.
Dr. Shu, I think I can answer this question as well. As we have a formulary that we use that's specific to sick kids, and yes, we changed that formulary when we changed our practice. Yes. And I'm not going to lie, it was a bit of a fight because the literature wasn't as supportive back then.
Exactly.
So if you're finding that they're changing the order, you might need to go back and see where they're getting this dosage from. And if you do have a formulary that's specific to your institution, you might need to make a change in that, or recommend that they change that for emergency specific visits.
Yes. Yes, I also tell the families, by the way, that if that happens, to remain on the 4 to 8 puffs rather than go to 2 puffs, because we sometimes anticipate this from happening.
Yeah, I think the concern is that they won't get enough medication, like in their prescription from the pharmacist.
Yeah.
And I have an anecdotal story about this where we had an RT doing research, and she would sit behind me every day, and every 3 or 4 days she'd come in exhausted from being in Emerge with her young son with asthma. And I finally just got frustrated, and I printed off what I shared today, and I said, can you please just do this at home? And it was the 8 puffs, and shortly after she came to me and brought me this basket, it was like, you've changed my life, thank you so much. And it really changed. Yeah, it really helped. And then she wasn't, and I gave her, when you need to come into Emerge and when should be. But, I just think the 2 puffs, it doesn't break them. It doesn't break the cycle.
And nothing gets into the lungs. This is the problem too.
Yeah, and if they're crying, and exactly like Dr. Shu said, if they're crying, forget it. And so then there's a question on, you are using 8 puffs regardless of age now for in-hospital treatment?
Yes, 8 puffs regardless of size or age or anything. Yeah. Now, there's nothing magic about 8. It's actually, I'm not going to go through the calculation because of time, but it basically has to do with the ratio of the dose with the nebulizer and MDI. Some centers actually use 10 puffs. But it's somewhere in the neighborhood of 8 to 10 puffs, yes.
All right. And then someone's asking the timing of megsulfate.
Yeah, so if you decide to give it, the earlier the better. So we usually, in 99% of the cases where we do give megsulf, it's given after the initial stabilization therapy. But it's important to give it soon enough so that you then have time to watch the child whether they actually respond or not. And that frequently doesn't happen. So megsulf gets given, let's say 3 or 4 hours later, and then people say, oh, well, let's just give it because I don't know what else to do. So I'm going to give him megsulf, but now we have to admit him because we don't have time to watch them. And it really doesn't do much, and they might come back if we send him home, they might crash. That's what a lot of people are worried about as well. So it's actually used quite inappropriately in the sense that it's frequently used late. So generally speaking, about an hour or so after the initial stabilization therapy, is, if you give it, is probably the best time to give it.
All right.
Okay, next question.
There is a question. Amani, can you unmute? And I'm not sure if I understand your question. I'm happy to read it, but it might be better if you just ask it. Maybe it doesn't have a speaker. Okay, so is prednisolone better than Dex after first dose of Dex? And if continue with Dex, would you go with 0.6 milligram per kilo times 2 days or longer?
Okay, so either. So if you, so first of all, prednisolone, the Canadian prednisolone has got a horrible taste. So in general, we try to avoid that if at all possible. But it is safe. If you decide to give so basically your choices are, you can give a second dose of 0.6 per you can give a second dose of 0.6 per kilo of dexamethasone on day 2. That's a possibility as well. And actually our inpatient colleagues use that in hospitalized patients. Or you can give a 0.3 per kilo on day 2. That's a possibility as well, because as I told you, there is really not much evidence in terms of superiority of any of these menus. Yeah, so any of those will be okay.
Yeah, typically we see prednisone used in our atypical asthmatics as recommended by our respiratory medicine colleagues. So I've worked with their educators to educate the families, because those kids will be seen in our asthma education clinic. And so, you know, we do try to coach them to coach that if that's a recommendation that respiratory medicine, that they need to inform the emerge about that. So hopefully the parents can give you some guidance on those kids. But for the most part, we always use Dex.
Yes.
What about kids who have been on methylpred, let's say for 24 hours, just do one more day of Dex?
Yeah, I think yes, I think that would be very reasonable to give one more dose of Dex, yes.
All right.
And there was another one I saw. There was something else about.
Did I miss something?
I forget what it was. There was another question.
I think I got them all.
That's it? Okay.
Yeah.
Perfect.
All right. I think that's
excellent.
it.
Excellent.
All right, everyone. Well, feel free to reach out. We're here anytime. Thanks for logging on.
Thank you very much for everything, and all the best. And you can email me anytime you have got questions as well.